Hello everybody. Today we're going to talk about the diagnosis and treatment of pulmonary embolus. Pulmonary embolus is a very common medical problem, and today you're on duty in the emergency department to see patients. It's a nice day outside, but the parking lot looks really busy. Wow, there are a lot of patients today. Well, it looks like the first patient is ready to be seen in room 6. Okay, let's see what we know about our first patient. Our patient is a 50-year-old female who presented to the emergency department with chest pain and dyspnea. She's currently undergoing chemotherapy for breast cancer. It's time to obtain a detailed medical history of this patient. You learn that the patient has a recent diagnosis of breast cancer and started chemotherapy via a central venous catheter last week. The patient has no other active health problems. The patient is a former smoker with a 30-pack year history. However, she quit smoking 2 years ago. The patient also relates a family history of early onset heart disease. What brought the patient into the emergency department is chest pain that began 1 hour ago. The patient describes the pain as crushing, retrosternal, and accompanied with severe dyspnea. The pain also radiates to the back and arms. So what's the differential diagnosis? It's really 3 things: acute coronary syndrome, pulmonary embolism, and aortic dissection. Supporting acute coronary syndrome, you have family history and tobacco abuse. For pulmonary embolism, you have cancer and the presence of a central venous catheter. And for aortic dissection, you have tobacco abuse. So what are the symptoms of a pulmonary embolism? Well, the symptoms are nonspecific. Dyspnea is the most common, present in about 3/4 of patients, and then there are other symptoms like pleuritic chest pain, cough, hemoptysis, and so on. However, these are not really helpful in differentiating one cause of chest pain from another. It's time to move on to the examination of your patient. Well, your patient is alert and awake, but appears to be in at least moderate respiratory distress. You recheck the vital signs, and the patient has a pulse of 114, a respiratory rate of 32, and a blood pressure of 93/75. Cardiovascular exam reveals tachycardia without murmurs or other sounds. There is no lower extremity edema. Patient's lungs are clear to auscultation bilaterally, but the patient is tachypnic. Let's go and discuss the exam findings. Your patient has a temperature of 37.8 degrees Celsius, a pulse of 114 beats per minute, a respiratory rate of 32 breaths per minute, a blood pressure of 93/75, and has an oxygen saturation of 80% on a non-rebreather mask. Examination of the patient's neck shows no JVD. Cardiovascular exam shows tachycardia without murmurs. Lungs are clear to auscultation. Lower extremities show good pulses with a negative Homan sign bilaterally. Initial testing with an EKG shows sinus tachycardia without ST elevation, and a chest X-ray is unremarkable. Physical examination findings with a pulmonary embolism are also nonspecific, the most common being tachycardia, seen in about 40% of patients, and tachypnea, seen in about 1/4 of patients. So how does this new information influence the differential diagnosis? We can add a few pieces of information to our differential diagnosis. The EKG is negative, the patient's Homan sign is negative, and the patient's pulses are equal, and the mediastinum appears to be normal on a chest X-ray. Unfortunately, the Homan sign is not very useful. The sensitivity ranges from 10 to 59% depending on the study, and the specificity is 39 to 89%. I guess we can take the negative Homan sign off the list. The Wells score for DVT performs much better. It has a sensitivity of 94% and a specificity of 45%. The Wells score for this patient is 1, which gives her a 17% chance of having a DVT. We can add the Wells score for DVT to our differential diagnosis. There is also a Wells score to predict the probability of having a pulmonary embolism, which has a sensitivity of 95% and a specificity of 27%. Your patient scores 2.5 on the Wells score for pulmonary embolism, giving her a 21% chance of having a pulmonary embolism. We can add the information from the Wells score for pulmonary embolism to our differential diagnosis. It's time to move on to testing. Your initial labs show an unremarkable CBC, basic metabolic panel, and cardiac enzymes. The patient's D-dimer test is positive. We'll add this information to our differential diagnosis. At this point, it appears unlikely that the patient has an acute coronary syndrome, and it also appears unlikely that the patient is having an active aortic dissection. With pulmonary embolism now being the most likely diagnosis, it's time to order specific diagnostic tests to see if we can confirm the presence of a pulmonary embolism. The most common way to diagnose pulmonary embolism is with a CT pulmonary angiogram. Fortunately, we have one right here. And the reason that CT pulmonary angiography is the most common test to diagnose pulmonary embolism is its high sensitivity of 83% and an excellent specificity of 96%. Where did everybody go? I guess we need to track down a radiologist to go over the results of the CAT scan. Reviewing the CT scan, you find a saddle pulmonary embolus, confirming your diagnosis of pulmonary embolism for this patient. If you're not able to do a CT pulmonary angiogram, there are other alternatives, one of which is a ventilation perfusion scan, a standard pulmonary angiogram, or a magnetic resonance pulmonary angiogram if available. Now that we've confirmed the diagnosis, it's time to move on to treatment. Because of the pulmonary embolism, the patient has a number of active problems, one of which is oxygenation, hemodynamics, and the pulmonary embolism itself. We need to address each of these problems. For the oxygenation problem, we can give supplemental oxygen. For hemodynamics, fluids, pressors, and other interventions. For the treatment of the pulmonary embolism, we can start low molecular weight heparin, Apixaban, or Rivaroxaban. You could also consider intravenous unfractionated heparin. And in patients with contraindications to anticoagulation, you could consider an inferior vena cava filter. Let's put in some initial orders. We'll give the patient supplemental oxygen, intravenous fluids, and intravenous unfractionated heparin on an anticoagulation protocol. Hope you enjoyed this discussion of the diagnosis and treatment of pulmonary embolism.